A warm welcome to everybody for our public board meeting. Lovely to have everyone in the room. Particularly warm welcome. We have a shared experience. We're going to hear from Emily, and she's supported by Julie and Maxine. So thank you all for coming. And we look forward to hearing your story, Emily. We also have, I think, welcome to Matt and sorry, I don't know your name.
No, I'm probably Turner and I'm the matron for KGHI.
Brilliant. Lovely to have you here. So welcome to everybody. And we do have just a couple of apologies for today. Mark Caulfield and Marta Phillips, two of our non-executive directors, can't be here. And Janine Rosa has had to go home and she's not feeling too well. So we have apologies from all of them. Other than that, we're all here. So the first thing we're going to do is hand straight over. I think, Julie, you're going to introduce the session. Then we're going to have a video telling us about Emily's story, but she is also prepared to take some questions and have a bit of a conversation afterwards if there are any points that we want to raise. So over to you, Julie.
Thank you, Sarah. Hello, my name's Julie. I'm part of the patient experience team, and one of our roles is to speak to our patients, get feedback from them, and we run patient stories. And Emily is one of our patients that had an experience in our maternity services this year. We're going to play a video of Emily's experience, and then after that, we'll be open to it.
Hello, my name is Emily, and this is my birth story. So, growing up, I was surrounded by so many positive birth stories. My mum had 2 natural labours, my sister had natural labours too, unmedicated, and they both raved about how amazing it was. So when I fell pregnant with my first child in 2022, I was excited for birth. I wanted the most natural labour. I didn't want an epidural. I was hoping for either the birth centre or a home birth, and everything was going really well. I was a low risk pregnancy. And then came along the 20-week scan and I found out that I had a low placenta, and I didn't know much about it, and I was told that it was likely to move, but we needed another scan at 32 weeks. So we had the scan at 32 weeks and we still had the low placenta, and we was told it needed to move to 2 centimetres away from the cervix. And again, we went away still hoping it would move. And then at 33 plus 4, I had a bleed with blood clot. So I was admitted to hospital for 24-hour monitoring, and we was recommended to have the steroid injections with the thought that maybe the baby could come sooner to develop the baby's lungs. Then over the next 4 weeks, we had more bleeds, and I was still desperate for my natural birth. So I was still aiming for that. And then at 36 weeks, we had another scan, and we found out that the placenta had moved to the 2 centimetres. However, when I met the consultant, he recommended that we still go for a planned C-section. Due to the bleeds, he felt that this was the right thing to do, and so I agreed. We booked a C-section for 38 weeks. Obviously not the birth that I had planned, but I knew that it was something we had to do. Then I went into labour at 37 plus 2, and so I had contractions and bleeding, and we had the C-section. Now, there was no problems with my C-section. I cannot complain about it whatsoever. It was better than I anticipated. It wasn't as scary as I thought it would be, and all was fine. However, it was not the birth that I wanted, and I still dreamed of that natural birth that I grew up hearing so many stories about, that it was amazing and all of this. So when, even weeks after my first baby, I was having conversations with midwives and health visitors. If I were to have a second child, what would that look like? Could I have what I now know is a VBAC? And they said that I could, and they had known people that had VBACs. So over the next couple of years, I researched it and I still very much wanted that to happen with the potential of having a home birth. And so when I fell pregnant in 2024, at my very first community midwife appointment, I told her that's what I wanted, and she fully supported it. She said she'd seen people that had had home births after cesarean and it could happen. She obviously outlined the risks. She told me that I would need a further appointment at 24 weeks, I believe, with the VBAC clinic. Now, I had read stories, I'd researched quite a bit, and I'd heard there was always a bit of reluctancy with consultants or medical staff regarding a home birth after C-section. So I had fully geared myself up for a fight. I thought that I was going to be persuaded into the C-section that I didn't want. So I remember driving to the VBAC clinic appointment at King George's, and I was trying to tell my husband, like, be prepared, they're going to tell us the worst case scenarios, they're going to really drum down on the risks and not really tell us the positives, but it was the complete opposite. She outlined the risks, she went through line by line a printed document telling us the risks versus the pros for both, for the VBAC and a planned C-section after a C-section. But she also made me feel like I could do it, and she was supportive that if everything went well, that I could do it. And then again at, I think it was probably around 36 weeks, I met the home birth team. And again, I was reminded of the risks. I was told that by choosing a home birth, it would be birthing out of guidelines. But I was also told that it can happen and it can go well. So just before 40 weeks, I went into labour, my waters broke, and my community midwife came and checked me and again reminded me, we're birthing out of guidelines. But she supported me and she made me believe that I could do it. And after 16 hours of labour at home, my little girl was born, and it was the best thing in the world. It was the birth that I'd hoped for, dreamed of my whole life. And we got there, and it's because of the support that I had during that pregnancy and all the doctors and midwives that I met that allowed me to have that home birth, or the natural birth that I had hoped for so long. I very much was scared in my second pregnancy that I was going to be persuaded into something that I didn't want due to the pressures from consultants or people who know better. And that has stuck with me. However, I'm very much grateful that during my pregnancy, that did not happen at all. I was fully supported. I wasn't spoken to in any way. All the conversations were two-way conversations. It was me also having an input into the care that I had, and what I wanted, and discussing the risks, but also the pros to it.
Wow, that was such a lovely story. Thank you so much for sharing. I was supposed to know what the outcome was going to be. So that was a really lovely, happy ending. That's really great. I'm so glad to hear you got your experience. But thank you for sharing the way in which it happened. That's really important for us. You were obviously, I mean, sounds like you were very clear in what you wanted. Maxine, were you involved in the support of the case at all?
No, I wasn't involved in it. Good afternoon, everybody. I work with, well, I'm a midwife, and also I work and now I'm a PMA. So I used to be a community midwife, but you know, is actually coming. I didn't, was not involved in the case, but I do relate to what you've been saying to it, the mental story that we like to use here, because we do empower women to actually, give that naturally, especially women. And as the community involved, I love that. So I really do convince my women to actually stay at home. And if they can, we always have a very good outcome. And we've been promoting that very well now.
So good to hear. And you're right. I mean, my sort of ignorant assumption was always if you had a C-section, you were like every other birth would have to be. So it's really good that you looked into it yourself, but also found that support that you could go down that route. Yeah. You've got two lovely children. I'm sure there's going to be some comments or questions, Andrew.
And it was really lovely and really brings out one of the real significant things we have to do as doctors better than we perhaps do. I've been running the heart disease and pregnancy service here and at the Royal London for nearly 30 years. And one of the things, we often look after women with much higher risk than you would have having a home birth after a section. But one of the balances it's really hard to get, and I hope we do well enough, is explaining risk to women who are either thinking about pregnancy or are in a pregnancy. And sometimes the risks we're talking about are really life-threatening risks to the mum. But not making them feel that you're trying to force them into a decision and allowing them to make a decision based on information, and then making sure that they feel that they're going to be looked after regardless of what their decision is. And I think that happened really well here, didn't it? And I'm not sure we always get it right. It's not just in maternity, but it's in many things that we do.
And it probably helped that you were willing to make your own decisions, because it's probably even harder for the clinicians if the patients are wanting guiding. You obviously very clearly wanted to have that freedom. You wanted all the information, but you wanted to make your decision. And the team helped you feel empowered to do that. Ruth.
So my name's Ruth Crowley. I'm a GP, but also here. Two questions from me. Well, one's more common, the other's question. I think what was lovely to hear from you also is how you knew what you wanted, but you also felt that you weren't stuck on that at all costs. Like, it was really clear, wasn't it, for you that safety of you and baby was paramount. It's just if you could, this is what you wanted. And I think sometimes our mums don't maybe have that balance in the same way that you did, which is really helpful when you did. And I also know how it feels when you're going to an appointment ready. And you've got your armour on, haven't you? And you've kind of worked yourself up. And sometimes the wind gets taken out of your sails because the fight never came. How can we communicate better to mums so that you don't feel that? How can we get it out there that, particularly in this area, so around this hospital, which I think has had lots of bad narrative around it, particularly around birthing, that one, things are better, and that we do try and put mums at the very centre of their care, and we want them to feel empowered. What would have changed in your journey so that you never felt like you had to go in for that fight? It might be you don't know, and it's just, if we could change something, what could we do?
Yeah, I don't know, because I was just, every person I met along the way, I was expecting someone to have a different opinion. Now, one thing I will say, my first pregnancy with the low placenta, every time I was admitted with a bleed, I was told different information from different consultants. So I probably came across, say, 5 different consultants. 3 times I was told my placenta needed to move 2 centimetres. And then 2 consultants told me, no, if you're in my care, it has to be 2.5 centimetres. So from that, I learned it depends who you come across. So that's how I then went into my second pregnancy, feeling like, okay, this person said, yes, I can do it. But the next person I come across is going to say, no, I can't. So that's
actually had the same, if you had continuity of the same consultant, that would have been quite key, wouldn't it?
Yes. And that's obviously what I experienced the first time. It was just whatever consultant I had was telling me what they wanted the placenta to be at. So I think that's what I then took into my second pregnancy.
Caroline.
I'm Caroline, one of the social non-execs here. Yeah, you spoke about your mum and your sister had these wonderful experiences, and I think when you go to have a baby, you hear all of that stuff. So you've got all of that stuff, and it's almost like quite a lot to live up to. But you had different experiences. Having seen both sides of things, what advice, if someone with their first pregnancy is coming to you, what would you want them to know about not exactly their rights, but their options having a baby?
I think women need to know that they have got options. I think a lot of people that I know probably go into birth thinking they're going to be told where to give birth or how it's going to go. I don't think many people I know they've got a choice, especially about home birth. I think a lot of people think you choose home birth if you've had a terrible experience or you hate hospitals, not that it's just somewhere that you can give birth and that it's quite common. Yeah, I feel like a lot of people I know that get pregnant, they're just sort of ready to be told what to do rather than, okay, come on, let's make a choice. What do you want? And things like that. So, yeah.
So in your second pregnancy, you were obviously quite thoughtful early on as to how you hoped it would go. So it sounds like you raised the question from the very beginning about how you'd like to give birth and where you're going to give birth. In your first pregnancy, that might not have been so much in the forefront of your mind. You might have had some assumptions. So when was the first discussion with you? Was there a discussion prior to your 20-week scan about the fact that there was either a choice to be made? So did you inquire, or was it
wanted a home birth? I had seen in social media and things about home birth. So my sister had given birth in the birthing centre, which I thought was amazing when I heard about that. But then on social media and things, I had seen about home birth, and so I'd already wanted a home birth. So I actually brought that up to the community midwife very early on.
in the first pregnancy?
In the first pregnancy as well. Yes, it was something that I had looked into and wanted more information about. So yeah, it was actually me that brought that up, I think, until obviously the 20-week scan.
You do sound like a model patient, I have to say.
Yeah.
Has all their own research and comes very well informed and has a view, but an open mind. I mean,
Yeah.
No, it doesn't work so well for everybody, I suppose.
Of course.
But, you're very much on the front foot. So I guess I don't know what our practice is as to how soon we start having conversations with pregnant women about when they might want to start thinking about their birthing plan. Because do we do that from the very beginning? Do we wait for them to raise it? I don't know whether Maxine was
We do that from the beginning. So when the woman knows that she's pregnant, obviously she's been seen within 6 to 8 weeks.
Yeah.
And that's during the booking appointments. That's when we actually last a choice of deliveries, and then we take it from there. We do have the continuity of care team. We have personalized care too, as well. So it's really from the beginning. The moment we need to see the stuff.
Yes, because some people will take longer and maybe not as well informed as Emily or as clear in their own wishes. I can see Abby's joined us. Abby, you've got your hand up. Did you want to come in?
Yeah, thank you so much. It's just to add to what Maxine is saying. It's part of our KPI in ensuring that our birthing people, they are informed about their place of birth and their choices in terms of planning whether they want a home birth, hospital birth, and our midwives, they talk through this along their pregnancy as well. If anybody wanted a home birth, and we've seen from risk assessment that things are changing. We discuss with the women and our birthing people in terms of what is changing, and have an MDT meeting with them, that our consultant and our consultant midwife, they will discuss the risk and everything. And for women and birthing people that English is not their first language, we're just rolling out bit by bit now in terms of our parent education, but we've been doing in different languages, but the uptake has been not as good as we want, but we're working on that so that we're talking to everybody in the language that we understand, just to empower their choices.
Lovely. Thanks, Abby. That's really helpful to hear. Any more comments or questions?
Yeah, I mean, it's an impressive story. I did feel actually quite emotional listening to it. And I was really delighted that you got your wishes fulfilled and that too, gave birth. But I think there is an opportunity here to potentially promote more around the home birthing service and also the midwifery-led unit, particularly when we know the pressures on maternity services around cesarean sections, and just really making sure that women know what their choices are and how do we provide the support. But it was lovely to see multi-professional working and you being actively involved in your care, which was really nice. Lovely way to
And sharing those good news stories, because of course you were really well informed and you were excited, but a lot of women in fact when they're pregnant they haven't necessarily had the experience you've got, and so they're quite daunted at the prospect of actually giving birth one way or another.
Yeah.
So hearing about the options and the good news that goes with it. So yes, you're right, we can do more to promote, just generally share information. Is there anything else you want to say, either of any of you, in relation to it? Emily, thank you. Thank you for taking the time to come and share that with us. It's lovely to hear a positive story at the start of our board meeting, and I'm delighted it was a happy hour. Thank you, and Julie and Maxine, thank you for coming along to support. Thank you. Thank you, everybody.
Thank you.
Right. Okay, so anyone need to mention anything under declarations of interest? Nope. Good. We have the minutes from our previous meeting, which was the 4th of September, our last public board meeting. Any comments, amendments to be made? Happy to approve?
Yes.
Lovely, thank you. Matters arising, we had a couple there to mention, so I think we're getting to the winter plan. As one of our matters arising under the last board. We got want to talk to that. Matthew?
I think it's probably better Fiona.
Okay,
So,
thank you.
Thank you. Just to present to board the process by which we've developed our winter plan this year. We've had a series of meetings across the North East London ICB, approaching the winter planning as a system. We were required by NHSE to start winter planning in July. Just to reassure everybody that we have been thinking about this for a while. Priorities from national are around delivery of the 4-hour target, 78% compliance, to reduce over 12-hour waits to less than 10% of patients, and to secure faster handover for ambulance patients in ED, 30 minutes. So those were the headline objectives. As I said, we worked through a series of planning sessions across the system with other acute providers, with London Ambulance and with the wider provider network across North East London. A regional winter meeting was held in September, and we have all confirmed our commitment to making this winter as good as we can for patients. Our final plan was submitted through our board subgroup Finance Investment Performance Committee on the 24th of September, and the board assurance statement was signed on the 30th of September and returned to NHSE within the deadline. In terms of ongoing monitoring, we will monitor the delivery of our winter plan and the metrics around the initiatives that we've identified through the integrated performance report going forward. And as per the past few years, we will submit a wash up of the winter activities towards the end of March next year as part of our governance. Thank you.
Thank you very much. Any comments or questions? Yep, we've all seen plenty of it, so thank you. Good to hear. In terms of the action tracker, there's only one item on there, and it's an open item. We're going to try and organise a consultant to come and share their experience with us at board, someone who's perhaps trained here, and I think we're aiming to do that before end of this financial year. So I don't know if we've got any progress on earmarking someone.
No, but it should be straightforward to do.
Brilliant.
Especially recently, we've appointed quite a few locally trained consultants.
Brilliant. Good. Thank you. Okay, updates from me and then from Matthew. So just there is plenty going on in terms of some of the things I've been involved in. So I'm part of the CQC well-led review. So I've had a couple of meetings on that, talking about their new approach to well-led. Obviously, the first one when we still had Julian in post, and the second one without. But assurance given yesterday's meeting for the CQC team that they don't intend to alter any of their plans around the approach to the framework and the well-led work, just because they're having a change of chief exec and it's well underway. Also gave evidence to the Senior Salaries Review Board in conjunction with NHS providers last week, which was an interesting session, and they were very happy to hear from Trust. There were a couple of us as chairs who were contributing to that. I also attended an NHS providers and IBM run AI masterclass, which was incredibly useful and informative. So lots to think about as we start to explore opportunities in the world of digital. More locally, we've had obviously a number of the APC chair and chief exec meetings, and we've had some of the ICB chair meetings. I think one of the topics of conversation that's come up quite a bit, apart from all the challenges for the ICB with all the changes going on, is a continued focus on the challenge we're facing with mental health patients. And off the back of that, I took Ian Jacobs and Rebecca Fulton-LeCoux from Barts over to visit the mental health and urgent care centre that we've got in Hertfordshire, that we've got on the Lister site, because Ian was looking for a bit of support. So I did invite ELF to come along, but it was very short notice and they couldn't. But it was a really useful visit. They could see how it worked, and I was able to sit then with the medical director of Lister, who talked through how, from an acute point of view, it's been so helpful. Sorry, and we talked about the collective approach from the acute and the mental health trust together to put in the business case that the ICB supported. So I'll be sharing the business case that we used in Hertfordshire and see whether we can help that move things forward in our system. And we do have, I think we've got in the direct keeps moving, an all chairs meeting that Marie Gabriel is organising to try and talk about the mental health issue for North East London. So hopefully in combination, we'll make a bit of progress on some of those issues going forward. Just locally, I've had lots of visits around the trust. I think I've sat down with virtually all of the service leads for all of the different divisions over the last few weeks, a couple of months anyway, and really useful conversations, meeting all of them and just hearing what people are really proud about, what's on their minds, just giving me a real sense of the day-to-day, what's going on. Visited the Frailty ESDEC, which given the current pressures, it was really interesting to go and see and spend some time with IO hearing about how that's operating. And had a really good day at the Cancer Strategy Away Day, which a number of the exec were also at, which was really excellent and thought-provoking. So plenty going on, and lots of the sort of internal rotational meetings with Freedom Speak Up, Guardian, Diversity Chairs, Health Watch, the staff side. So just getting lots of input in terms of what's on people's minds. But I think fundamentally, the main focus and the pressures on us all at the minute are very much around the finances, the medium-term planning and all this sort of noise in the background is context, but we've got a very tough job to do, and there's a lot of things going on in our trust that I'm sure Matthew will talk about, that are some of our current areas of focus. So let me hand over to you.
Thank you very much, Chair. So there's quite a bit in my report, but I think I'll focus on probably two things, one which is the electronic patient go live, which you can't miss if you've walked around like our hospitals recently. So, and the rollout of the EPR is on track, and we completed the data transfer between our previous patient administration system and Millennium on time and with a low error rate. And so that was real progress from the issues we identified earlier in the year around that. So some good work done there. We're now in downtime as of last night, which means we're running our hospitals on paper using business continuity plans, and that's pending Millennium going live on Saturday morning. The trust has been busy. Our main pressures at the moment are probably in A&E at Queen's, but this is due to demand rather than the go live. This is pressure that's been consistent throughout October, and both sides are calm and the pressure is being managed well. As anyone is at a walk round, as with the A&Es last year, so we've seen. Prior to the go live, we sought and received approval from NHS England to go live, and to do that we had to provide assurance about our technical and operational plans for the change to the new system, about our plans to manage risk during go live, and the plans to recover performance against key access standards, because we know we will slow down, have lower activity levels for a period of some months after go live. So we have to provide assurance around that, and we've got the sign off to proceed. The mood on the wards and in the services is good. The staff are trained, the equipment's ready, and many of our staff are experienced users of BPRs, having worked elsewhere in the NHS, including anyone who's worked at Barts and has used Millennium before. And we're providing extensive support to people during go live and for the first 6 weeks after go live on both sides as well. I should say, I think this is the best example of collaboration between Barts Health and the HRET I've seen in terms of new collaboration since I got here. You know, we've got long-standing clinical networks like cardiology, critical care that work very well. And this was a new piece of work. And it's been a model, I think, of how providers can support one another to improve patient care and safety, and how they can share knowledge and expertise across the two. So particular thanks to Sarah Jensen, CIO at Barts, and to Charles Guttridge, who's their CCIO, and Louise Hicks, who's their CMO, and working extensively with us over recent months. And their team have been supported with cutover. So we are where we would want to be with EPR. We will keep you updated on progress over the weeks ahead. As I said, 10 o'clock Saturday, big switch on. The other big bit of news, I think, which is mentioned in the report, is we were one of the trusts selected for the investigation into maternity services led by Baroness Amos. We were the first trust to be visited, and we had a 2-day site visit this week, which included the investigation team meeting families affected by poor maternity care offsite, and then coming into Queen's, which is where our maternity unit is. We expect a report in due course. The visit was thorough. It was, I think, focused on learning and improvement as well as on the family stories. And the investigation team spent most of their time talking to clinicians working in the services to get their take and that sort of shop floor view of what it's like to work for us in maternity. They did meet the executive team and leadership team from Women's and Children's Health. But I would say the weight of their time was spent walking the floor with labour ward coordinators, midwives, obstetricians, and speak to women who were using the services at the time. So as I said, we'll expect that report in due course. We're also expecting the latest CQC report on maternity services to be published before Christmas. So I think the chairman of that points are right.
Thank you very much. Any questions? Lovely. Satisfied all your interest. Good. Thank you. Okay, let's move on to quality and safety. And we're going to go to the Quality Assurance Committee report. I'll start with you, Hilary. Thank you.
Thank you. So nothing for escalation to the board, as the report says, and the only item is the CQC survey, which of course was received at the private board a month ago. I think I would like to say, though, as you'll see, the vast majority of items were significant assurance or significant assurance with minor improvements. The only item for partial assurance was the CQC adult inpatient survey, where we have a plan. I don't know if there's anything you wanted to raise as well, Andrew, but I'm really encouraged, because if you compare that with previous 2 or 3 quality assurance committees, that's much more assurance than we have generally had.
And we also managed to finish on time, as Martin's not here. So we finished with a few minutes to spare and had a break. So it all felt like progress.
But I think it was a good meeting and
Good, thank you. In which case, the one of the items under there then is our update, the quarterly update on maternity services. Nick, you go, is Abby going to talk to that? Thank you, Abby. Over to you.
Yes, good afternoon, everybody. I'm going to assume that the report has been read, but I'll just touch on three key items on under items for noting. The key one I'll just let you know is in terms of our perinatal deaths review and the changes that was made in Q1. So what has been done is we've now include all neonatal deaths that occurred outside the trust in this report. This change is done in alignment with Embrace UK standard, which require the inclusion of all neonatal deaths of babies born at our trust, regardless of where the death occurred. So under this, we will see in Q1 2025 that out of the 3 deaths that we had, 2 was internal and 1 was external. And this actually is some of the actions that have been taken and sort of press the need for more coordinated, innovative approach in terms of our care. Especially, we will see those 2 babies that were lost were within 22 weeks gestation, and we don't have a level 3. So it's kind of something that has been raised and is on our risk register because they are extreme prematurity and it takes time. Them being transferred out may delay some of the way that optimize in terms of their treatment. So that is in terms of our perinatal losses. The other thing I just wanted to point to is in terms of the training, NLS training compliance. We said in this paper that in terms of our neonatal medical staff, they were 56.33% at that time. By Q2, I can assure you that now they've all done their training and they're 100%. The last one that I will touch on is in terms of our claim scorecard. The claim scorecard has been presented and triangulated with our incidences, complaints, and we've done the action plan. And the key things, some of the things that we're focusing on from the triangulated learnings is in terms of shared feedback from service users who reported inadequate pain relief. And from this, we form a task and finish group and have put some system in place to keep addressing this. I've touched in terms of the missed opportunity for optimal management of preterm baby due to lack of level 3. And the service identify a need for develop a competency assessment for improving medicine management and administration. Thank you. Any questions, please?
Thank you, Abby. You answered my question because I was going to question the level of training, but you've given assurance that the neonates it's up to 100%. So that's really good to hear. Thank you. Leslie.
Yeah, the only question I've got, and it's probably one for both you and Nick, and it's really, is it something that we are keeping a close eye on, is when you look at the percentage of births by ethnicity that resulted in a perinatal loss, that the in terms of Black Caribbean, it is way out of kilter. We know that's a national issue anyway. But it was really, what are we doing to actually focus on that and to ensure that all women who give birth here have an equal chance of having the lovely success that actually we heard from Emily earlier, because we want everybody to have that same positive experience, and the data is not showing that that's the case at the moment.
I'll let her come in first.
Yeah, in terms of your question, just to answer regarding that, we're keeping a very close eye in terms of our data, and a lot of some of the work we're doing, which we started last year. Some of the work includes our women that had the stillbirth cluster in some of our area, which was RM10 and IG1 and RM10. What we did, we started continuity of care in those areas. This year, I can confidently tell you from the data that the stillbirths in those areas have significantly reduced. And we've just rolled another 2 teams to another area. And it's not because that there were clusters of stillbirths in those areas, but we're starting to roll it bit by bit. The additional thing we're doing is we've introduced our bilingual parent education classes that we're trying to promote in terms of the women's, our birthing people's uptake. Then going forward, latest by January, parent education will be in terms of an opt-out for our birthing people, because what we've seen is women are not taking them up, and it takes some of our women from this background, not just from the global majority, to come in when they have reduced preterm moment. So we're doing a lot of work towards that.
And we're monitoring it through the maternity safety champion group as well. So we're seeing the data kind of every month, so not waiting on the quarter. But I think some of the good practice that Abby's described is beginning to see a little shift in that data. So I think the next report will look better in that area.
Thank you. Does that answer your question?
It does, but I think can help ask colleagues to provide some more context. But my points were going to be around what we've seen in our patch, and it's not exclusive to our patch, but it is the increase in the health inequalities gap over the last few years with the increased demand, and I can see you nodding, and that does leave us with some real difficult challenges that we face at our end, but it's not reflected as a kind of whole system or national approach towards that. I just wondered if you've got the evidence that backs up the comments I've made, and sort of how you're adapting and being responsive to those changes in deprivation and inequality.
Go ahead, Abby.
Well, thank you so much. There are other metrics that we're looking at as well. Prenatal hypertensive screening, which we've started about 3-4 months ago, but we're going to be keeping an eye on it because we can't start seeing the impact of the intervention yet. So hopefully by April, June next year, we should start seeing the impact gradually. And Catherine is going to come in as well regarding it, yeah.
Catherine.
Thanks very much. Yes, I was going to mention some of the initiatives that we've got specifically aimed at this population. So we've got the preterm preeclampsia screening programme. We've got some new resources in management of hypertension, a hypertension clinic that's going to come online, and also revising our diabetes service to make sure that we're meeting all of the elements in the Saving Babies Lives care bundle, which will really positively impact on this patient group. We've also fed really closely into the NEL maternity and neonatal demand and capacity work, and a large part of that work has been thinking about what new care models are going to be required for now and for the future. And thinking about public health initiatives, primary care initiatives, and how those, impact on the health of service users as they come into the maternity service. So we're actively engaged in all of those conversations and thinking about those care models as well.
Thank you, Catherine. That was really good to hear. Okay. Really helpful update. Thank you very much. So let's move on. Andrew, we've got the learning from deaths quarter one report.
So the learning from deaths report was presented by Wang. I assume everyone's read it. We're doing pretty well with our main indicators of mortality. You can see on the 2 graphs that we're doing better than our peers we compare to, and certainly with HSMR. Hospital standardized mortality rate. Happy to take questions on that.
Thank you.
We'll have the annual report next. It's going to be presented at the plan in November.
There was a question, but I was really pleased to see the comment about the urgent faith death cases and the weekend service being really helpful in the timely release of bodies, because remember when Nick and I found over that was something
Yes.
that was of frustration, and it's great to see that combined working is obviously getting a better and more rapid service, which will be welcome for our.
Yes, and the medical examiner, the introduction, medical examiner service became statutory just over a year ago. And that was one of the worries, it would slow the process down. I think we've worked really hard to avoid that.
Good. Thank you very much. Okay, let's go to the summary of the safeguarding and disability and dementia reports. Nick.
Yeah, this was also presented at QAC, and I'll take it as read. I mean, I just want to say, I mean, I think it's a great report, and it just shows the amount of work that the safeguarding and team are doing across the trust to make sure that, you know, our patients and service users are safe. I think there's a couple of good things I'd really like to pull out as well about having a youth worker and ED to support our younger patients who are very vulnerable. So hopefully that will help. And we've managed to successfully recruit into some of our learning disabilities and nursing posts, which means that patients that need some additional support can have that, and that resource is there and is helping us to drive through our reasonable adjustment work, which hopefully will help with compliance. And again, credit to the team around the training and actually getting into clinical groups and departments to ensure that, you know, the training is where we want it to be, or at least we continue to work towards what we're aspiring for. But it's lots of hard work in here.
Absolutely, and a really broad range of initiatives that are all putting together to make a difference, because it's there's a mixed and complex, I suppose, range of moving right across all of our different departments and services, and it's good to see what exactly progress.
So yes, that's really positive about the training, because for a number of years that's always been a challenge. So it's really good to see that safeguarding training is really now up near the levels where we'd want it to be. Because your challenge is to keep it there and get it even better. The two sort of questions, comments I've got on, one was on safeguarding children's activity, and I think it would be helpful, and it just strikes me as a bit of an omission, that there isn't any reference in the safeguarding activity to the issues faced by young people with mental health needs in our ED for prolonged periods, because that is a safeguarding issue. Especially if those are looked after children, and we know that quite a number of them are looked after children. So I would have expected to see some reference to that in the children's safeguarding report, because that's probably one of the bigger safeguarding issues that we face. And then my second was on the learning disability and autism, where it talks about the number of people that were seen, 696 adults and 274 children. But of those children, only, 512 out of only 89 children had or were provided with a passport template. And they also discharged before they could see them. This is likely to be because they attended the hospital over the weekend and not available. That's actually quite a high percentage of children that actually didn't get that. And I suppose my query is, do we follow up on that, and do we make sure they get that, or others? Do we have to rely on them coming in Monday to Friday when the team's there? So how do we make sure that that quite large number, I can't do the maths in my head, but 180 odd young people do actually get a passport at some point, because presumably they will be coming back to us?
I think the first point you make, I'll take back to the team to make sure that that's included in future reports as well. And the second part, a lot of work has been done around this, particularly within ED, paediatric ED. And again, I'm hopeful that we'll see a shift. So we've done some bespoke trainings, make sure that we do, make sure patients are coming and can get the passport. And also with the recruitment of these learning disability nurses, one of the things that their role is to do is to empower people to make sure that happens. We also had a presentation in WAC around learning disabilities in ED, and that included the passport, and there has been improvement, and that's why hopefully see a shift that happens without any additional information.
And I would add to that, one of the members of CLAC, who's the patient participation rep, is very clear on this. So it always gets interrogated.
I think it's something probably to come back to quite maybe it's about the safeguarding. So a lot of the data is around referrals, but not about outcomes. So what actually met threshold for them further safeguarding, and how do we follow any of those through? And I think with the EPR coming, there is a lack of sharing information that goes back to other stakeholders. So particularly back to primary care, sometimes we'll just get a safeguarding was put in, but then no extra information about what that was really about. So it's quite hard to follow it up. So I think just as a moving on thing, as improvement stuff, I think that would be particularly helpful.
Yeah, no, that's no problem at all. I'll certainly feed that back into the team. It does make sense. So thank you very much.
Not sure. Oh, sorry, Caroline.
I love your easy read stuff. I make a plea that you roll it out more widely, because so many people when they come to the hospital, you just physically can't take in some of those things. So I'd love to see that rolled out a bit more. Also, I think having the extra support, like for the mums, who have learning disabilities and things like that, and their families is so important, particularly because of the genetic thing as well. So you often you might be dealing with one person, but in fact there's a whole other ecosystem going on.
Just something in my mind, I'm not sure if it's an issue, but in terms of children's safeguarding, think about the mental health patients in particular. Not sure if it falls within safeguarding, but it's an oddity, isn't it, that within the acute sector, children and adults need mental health patients from 16, and yet if they were in the mental health services, they'd be under CAMHS. And I just think there's something that we just need to think through. Is there anything additional we need to do, particularly when they are looked after children, supporting them through that sort of sensitive 16 to 18, if they're with us because of mental health need, and ultimately we're looking to CAMHS perhaps to support them longer term. It's just a complexity to throw into the mix. Thank you. Okay, we can move on. Caldecott Garden.
Again,
sorry.
So this is the report for 24-25, was looked at QUAC again. So I'll take it as read. I think the highlights are we're getting much better at processing freedom of information requests and subject access requests, which is good and important. Our number of information governance breaches has dropped off, having not been as good as we would have liked. The main bit of work that we've been doing through Caldecott Guardian, looking at data, of course, is the share between Bartel and ourselves with the EPR, but that will come in next year's report. It's been a big bit of work. Any questions, I'm happy to take.
Okay, thank you very much. So that takes us to safe starting.
Yes, so this paper has also been to I think a couple of subcommittees of the board, and this is our 6-monthly required safer staffing paper, which is based on May data but written in September, just looking at safe staffing. I wasn't going to go into too much detail because, as we've discussed in the kind of subcommittees and other forums, the next paper that comes to the board will look slightly different in terms of we're moving away from the amber, red, blue, and moving more into talking about patient ratios. And that's been rolled out now. I think the important thing to say that is in the paper is it does demonstrate that staffing is safe and shows the improvements we've made in terms of recruitment. Also reviewed maternity services and the birth rate plus rate changing slightly with our review. And again, credit to teams for their recruitment and their retention work and some of the work they're doing around sickness and driving down temporary spend.
can't help but notice, of course, one of the consequences of the pressures in terms of the mental health patients in our hospitals, that we've had to recruit additional mental health nurses, and it's just an additional cost, and absolutely the right thing to do to provide the right level of support. But in terms of the overall system and shape of provision, given the pressures we're under, it adds to that pressure. And also noticing the areas where we've got continued pressure for agency use, again, in relation to mental health, but also the ED corridor care and maternity service. So well known to us that these are particular areas of pressure, and the demand information we've seen that shows the continued pressure and demand on our services explains it, but it doesn't help with our financial pressures. So but thank you, and of course the main priority of safety and safe staffing. Thank you. Okay, and then we've got the CQC, National CQC survey results.
Yes, thank you. That's also been to QAC and been discussed in the private board as well. So we're actually in the survey period now. So patients who are coming in as inpatients will be in the next round of the survey. And this data is based on last November patient cohort. So I think you'll appreciate as a board that the patients entering just now will be under particular challenges. We know our ED is busy, as we touched on earlier. We've got a robust action plan in place, focusing on kind of a reset around quality and personal care. We've met with our catering providers and our matrons just to remind them about the options again for food and ensuring patients have got adequate food and drink and available menus. So we've done a piece of work around that. We've increased our senior nursing walkabouts and visibility, and we've linked in with some medical colleagues and HPs to join that task and finish group, really trying to understand about patient experience on a daily basis. I think it's important to say that we shouldn't just look at these results in isolation. We also have monthly friends and family feedback and complaints that we can get a rich source of information from in terms of patient experience. So it needs to be triangulated. And we know the response rate is relatively low and not sensitive of the population we serve. And that's something we're very aware of. And we want to work with external partners, similar to what we're going to do in the cancer space, around trying to capture some of that data at a more local level, just to see what's impacting on inpatient care. So we are really taking it seriously. We recognise it's a gap, and we want to try and provide services that meet the needs of the population, as opposed to being designed around the process of the small number of feedback that we get in this report.
Thank you for the report and for making reference to actually what is quite a low response rate, isn't it? And decreased, albeit slightly. I was interested in whether we think it is a valid report, therefore, because the response is so low. And if we have doubts about it, how we have triangulated it with the other sources of information that you referenced. So I guess there's two parts to my question. What is it that we can do to increase the response rate? And are we confident that what it's telling us is consistent with all of those other sources of information? Thank you.
Thank you, Sue. I mean, if I'm completely honest, I do think some of the information in this report, although it's got a low response rate, does triangulate with what we see in terms of complaints, particularly around nutrition and feeding of patients and assistance. And one of the things we want to do with volunteers that we don't currently have is set up a dining companion scheme where actually people can help assess with feeding. And we've done a lot about protected meal times, but maybe we've gone a bit too far around protected meal times. And actually, maybe we should be looking to be more actively involved in helping us. And there is something about basic care and just reminding people of those essential things. So I would be misleading if I didn't say some of it does resonate. So although there's a small response rate, I think we have to act on some of it, and hopefully see a shift in some of the complaints data as well.
I've got Leslie, Mahbub and Caroline.
I think by implication,
you've sort of answered what I was going to say, but I'm going to say anyway, just to be sure. Because this is absolutely, as you said, not in any way, shape or form representative of the communities across the 3 countries. So So I know you do a lot of other things. Are we assured that the other things we do are more representative? And are we continuing to strive to make sure that the feedback that we're getting outside of is representative of the community? Because as you say, we can't design our services around a relatively small number which doesn't represent actually the people that we see in our hospital that we walk through.
Yeah, I mean, this is a refresh what we're doing now. So I can't necessarily say what's previously happened, but certainly the work that we're doing now is definitely the meetings that we're in is about trying to get that data for now. So I think there will be further improvements that need to take, well, I know there'll be further improvements that need to take place to be more representative. And we see that even in the cancer report as well around deprivation and poorer outcomes. So I think there is much more we need to do in that space, and we need to make sure that it is meaningful. So we have to collaborate with colleagues to do that. And it's an initial phase.
I was going to say, first of all, thank you very much for this report. There's lots of information and analysis leading to insight in here. I see this as part of the journey that we're on, and notwithstanding comments by Leslie about more patient engagement involvement. A summary version of this would be really helpful, I think, to share with some of our external stakeholders. There are lots of other partners out there who, particularly I think the voluntary and community sector, who, if we engage them in a forum of some sort to reach some of the more socially excluded and the seldom heard voices in our communities, would help us to develop this further. But I think it's also really helpful from a person who's not unquack, is to know that where the risks are and how you're mitigating those risks in real time. So these risks are big, huge risks for your staff. And thank you for the work that you do.
Thank you. Just a final comment. It was really good to see the positive feedback around the virtual ward, and that is working for our patients. So I think that's really positive to take that away, that has got the feedback around that's really positive.
Helen, I think it would be helpful if perhaps come back to practice at some point. We have a targeted discussion around this, because there's lots of stuff here, and it strikes me that a lot of the answers are based on expectations. And if looking at the demographic, you might be coming in for a care setting where, the lead is from hospitality. You're going to expect very different things to coming into a hospital. And some of the things also contradictory, like there are some things around care where it's great to be informed, but quite frankly, you don't want my decision about what we're going to be doing with certain things. But I think if we're able to have a look at some of the people saving area, I think that would be very helpful. Also to do with like stay, because some of your long stayers may have very different views on some of these things.
Thank you.
Yes, Louis. I was just wondering if it's worth involving the patient experience team in that, because we are really scraping the surface here, and it's not a representative surface, as everyone said. So, but that's been the case for 2 years in a row now. So there must be another way of getting, whether it's the way we engage with PI fake QR codes, what other things you can use as a way of giving feedback in more real time. I mean, I would be interested to know what the national picture is for CQC, because this survey isn't good value for money for the NHS, frankly. An awful lot of postage, for not much return. Thank you.
It's interesting seeing how these kind of quite old-fashioned paper-based surveys work out now. And the demographic position, those of you on the Barts board will know we get the same kind of feedback outside through that. There's other issues as well to do with some of the makeup of our local population, where some people are less willing to raise their voice about the quality of the care they've experienced because of other concerns. As well, we've certainly found that talking to some of the local communities, for example, in Haven Council Department, There are people who are reluctant to comment on their experience with the NHS because of fears about consequences potentially from doing it, from depending on where they come from, what their experience has been of working with government agencies, government bodies as well. I think the era of the paper-based fill this in and post it in surveys being something that really represents patient experience as well behind this. I'd take points about things like QR codes. I think it was really useful. I think more group-based work, more conversations with people in their community, and all the work we've done during COVID that proved really effective through, for example, faith-based communities. The kind of work that Steve and the team do as well, out and about, on the ground, on the wards, being approachable to people, really important as well. So I think this is a part of the picture, but as we know from our own patient panels, from those much more detailed opportunities to really get on the patient stories, there are better ways to do this than the CBC survey. It doesn't undermine what it says because they are valid experiences of a subset of people who've used our services. And it's important because where it points our attention. But it needs to be seen within the context. So if we know the constituents of our hospitals, this survey does not represent the vast majority of them, and we've got to do more work on it.
Is there anything else in relation to the specifically the cancer patient experience that you want to talk about?
Well, I've mentioned about, you know, the deprivation, you know, links to poorer outcomes. I mean, the cancer team are doing a great job as well around re-looking at holistic models of care and personalised care to kind of meet the needs of the local population. And then there's a good opportunity in here to align our services with the national guidance around stratified follow-up, and we set a health target 2026 around that. And you'll see from the people we are working with external colleagues around, you know, doing things in the community to try and make cancer experience as much better. Really.
There's quite a lot of discussion around the this report, the Cancer Strategy Away Day, so it's getting plenty of attention. We can see that.
It's the deprivation issue, and we've just been that the estimate of the impact of being on a cancer pathway about being £800 a year. And when you think about some of the populations that we have, that's just way out of people's affordability. And it just, going back to the issue around health inequalities, it's shocking that people are likely to be impacted because of an inability to actually be able to cope with the impact of food, you know, going forward, not for now, but we'll just be interested about some of the things that we are going to be doing, actually trying to address that balance so that people who are the most deprived in our community are not disadvantaged because they happen to be suffering from cancer.
Okay, and finally, this section, the Integrated Quality and Safety Report.
Okay, I'll take the report as read. There's quite a lot of information in the report. I just wanted to pull out a couple of points or 3 points. One, we've talked about duty of candour in the last board meeting, and we've talked about it at QAC, and we're doing a piece of work around how we can improve compliance, but we're actually taking a step back as well and looking at what the actual requirement is around duty of candour and making sure that we're not setting ourselves a target that we're bound to fail by default. So that's part of the piece of work that we're doing. And we are hoping that it improves with the EPR system as well, because it'll be easier for us to access. And we're working with the clinical teams around raising awareness about the importance of duty of candour. The other thing we've done is we've done an observational review around medicines management, as well as look at the data. We've gone out in some of the wards at medicines administration time. It was really positive to see that the challenges are not necessarily related to staffing. And again, we hope that with EPMA, there'll be improvements in terms of quality of prescribing and administration, and also with the new drug trolleys, they'll hopefully make a difference, and we'll start to see a shift in some of the medicines incidents reported. And then the final thing, which you're cited on, is we're rolling out the new risk management process to align with the BAF, so that we're using the same terminology through the organisation, and that's going well, and clinical teams are engaged in that process.
Can I just question, I think maybe it's inferred my understanding. So right at the beginning, just in the exec summary there, under safe, we've got that there were 554 incidents of Parkinson's bed days reported in months, which is above the trust target of 45, significantly above. I just wondered if you could help me understand how I should interpret that context-wise as to what it's telling us. Because yes, it talks about a positive reporting culture, but it also.
Yeah, I think that feels rather excessive. If I could just check that.
Would you mind?
Yeah.
No problem. Thank you very much. Okay. Be helpful. Any other comments or questions? Okay, thank you. Let's move on to people and culture, and we'll start with the report from the committee meeting in September and October.
So I wasn't going to say much about September because I gave a verbal update to board that immediately followed that one. So I think issues that came out of that meeting have been picked up. Just in terms of the October meeting, I think what has been really encouraging is where we were at the time on the completion rate on the staff survey. Given we'd set ourselves an ambitious target, and we have improved the completion rate year on year over the past 2 or 3 years, and Ginny and the team have been doing a great job on that. But we were at the stage that we have the report, we were above the national average at the stage. So hopefully what we will get is some really rich data back from that when we get the report back in the new year. The NHS self-assessment is on the agenda anyway. It's probably the thing that takes up most pages on the agenda, isn't it? I mean, it took up most of the pages on the People and Culture Committee agenda. A long document, but not Andrew's fault that it's so long, it's somebody else's. I think the issue where we are still keeping a very close eye on is the issue around quality improvement in senior recruitment. And actually, we kind of extended the discussion slightly at PCC because what we were also keen to understand, given the ethnicity and gender pay gap trends, was not only what are we doing about increasing representation at the moment, but what we're actually doing around career progression for our lower paid staff from underrepresented groups, because they're not immediately going to become doctors or consultants if you're working as an HCA, but what are we doing about helping people just feel there is a ladder that they can move up? And we know that Kenny does brilliant work on career maps for people. So it was about us trying to understand not just what are we doing at the top end, but what are we doing at the bottom end about helping people move up. The work that we do in apprenticeships is hugely important in that. I hope that in the new year, we'll be able to bring a report to board that actually pulls together all the work that we do across the organisation on training and work experience for some of our more disadvantaged young people, particularly those not studying at some new for all sorts of reasons can't get work experience because they don't have a get to it. And the work that we're doing on apprenticeships, because I think we've got a really good story to tell as a trust about how we are really playing our part as an anchor in ensuring that people from our local communities work in our hopefully coinciding with our annual apprenticeship awards, which will mark your first anniversary, won't it?
It will indeed, yeah. I think that was day 3 or 4.
Yeah. That what we can do is bring back something on recruitment that just shows what we do around training our staff. And I think that's probably certainly overall.
Thank you. Okay, so the next one specifically, as you mentioned, the NHS England self-assessment placement provides quite a lot of data.
Yeah, so this is a statutory requirement, 67 pages.
Yes.
I was going to bring out very much what Leslie's just brought out. So page 63 of our report talks about the work that's being done to support young people getting into careers, whether it be wanting to be a doctor or working in nursing or anything else within the trust. We work really hard to do that. I think we do very well. much of the rest of the report is a combination of tick boxes and some comments. I'm happy to take questions.
Let's draw attention to one of the things in there, which is about healthcare scientists and funding for their professional development. Both Andrew and I have spent some time with Keely Quates, who's our lead healthcare scientist at BHRAC recently. We've got around 600 healthcare scientists working within the trust, and they are some of the most highly qualified specialists we've got working in every area from radiation protection to all kinds of different support roles across pathology, radiology, etc. And they are a key staff group in the 10-year plan. And they're a key staff group who doesn't have any national funding framework for professional development. So unlike any of the other clinical professions, there is no funding allocated to them. So as a consequence, within the trust, we've got a range of things, and from people self-funding, courses through to where line managers have been able to secure funding, where we've tried to secure partnerships with external providers, etc. We've spoken to a range of other trusts who are doing everything from using charitable funds to fund CPD from healthcare scientists and through to partnerships with industry. And we do have to work hard sometimes to avoid losing people to other trusts who pay some very healthy incentives and retention bonuses, etc., for people working in radiation protection. And some of those areas where there's a very competitive field to recruit. So I think it's an area where we as a trust need to take a view on, so if you think, for example, if a £500 per head investment would be around a £300,000 cost for us as an organisation supporting CPD. I think there's a conversation for us to have as a board, but probably also as a wider service within London and with Ruth Thompson and others at London level. And because healthcare scientists, pharmacists are critical to the delivery of the 10-year plan, and yet it feels to me they are disadvantaged by not having the kind of national support that some of the other professions.
Yeah, I mean, these are some of the unsung heroes within a busy hospital. They're often hidden away in bits of the hospital that most people don't enter. If you come in to have treatment for cancer, for instance, someone will be sorting out the maths of the radiotherapy you're going to be given. They often have PhDs, incredibly well qualified, but paid much less than others with similar qualifications working in industry, for instance, but choose to work in the health service. I think it's really important that we support them and allow them to develop their skills and keep up to date.
Is there not a professional body that they belong to?
There are a really heterogeneous group. So some of them will have professional bodies, others won't. Where they have professional bodies, they're fighting hard together to try and secure a standard level of funding that should be part of a strategy requirement of trusts. And whilst it's not, we don't get given the money to finance it. It really is important.
Yeah, important.
So it's been a Cinderella group as long as I can remember. I remember having the same issues 20 years ago in Guildford. They've never had a voice that represents their value or the compensation, frankly.
We appointed, so Keely is our first formally appointed lead clinical scientist, and is doing a great job publicising the representing. I mean, you go from people who are involved in hearing tests to those who do the physics for radiotherapy, those doing radio protection, all sorts of people within many departments.
Just being a complete pedant, as I often am, I noticed item 14 and item 23. We don't seem to have ticked any boxes, and I don't know whether that's an omission or intentional, but there's nothing ticked, so that might just be looking at.
Have a look at it.
Yeah. Okay. All right. So having covered that one, we've got the staff survey update. And we're going to get with that too. Yeah.
Yep. So staff survey, we are well into it. We're running above the national average at the minute by around 5%. And we've just had more than 40% response rate. With the survey running through to the end of November, it's worth remembering 2 years ago, our total response rate of the year was 41%. So last year we did 55%, and I think this year, again, the team are pushing for 60%. We have had some competition for people's time recently in terms of EPR training, etc. So we are going to let folk get through this week or two and then have another real push on it. What's been particularly heartening this year has been seeing a number of the clinical groups, really strong levels of response rate there. So it used to be corporate was very high and others were kind of in the middle or towards the bottom. Actually, some of the highest performing areas of the trust this year are in the clinical groups rather than corporate functioning, which is really good because it does mean that we get a very compelling response from staff that work to work there. Last year, some of the key issues that were raised were around burnout, around people coming into work when they're feeling unwell, and also around violence and aggression as well. Some updates in the paper and what we're doing there. Some of this will be helped with some more consistency reporting, introduction of electronic patient record, but also looking at incident reporting so we get a better understanding and better consistency in terms of how we're reporting some incidents. So as the committee heard, and Leslie's chair will be aware, some of our reporting on violence and aggression is sometimes difficult to aggregate because people are reporting things in different ways. People have different tolerances for abuse in the workplace as well, depending on where they work and what they're used to as well. So what we're trying to do is to introduce some more consistency in that. I think it is worth noting also in there that the location of some of the violence and aggression, which I think maybe 5-10 years ago tended to be around emergency departments, it is now much more widespread in areas like antenatal care and scans and car parks, which are a bit of a hotspot from time to time as well. And we've been working with our security teams, trying to make sure that staff are better supported, and also using things like de-escalation training, body cameras, etc. And that's all been part of the USAID we did for staff to try and push up that response rate. So if we meet the 55 we did last year, I'll be really happy with that. I think given the EPR rollout, I think Janine and the team has got aspirations to go higher, so we will keep pushing right through to the end of November. And if there's anyone around this table who hasn't done a staff survey yet, I'm strongly encouraged to do it. So, thank you.
Thank you very much. Good to hear. Okay. Let's move on to financial reporting. So we've got the Financial Investment and Performance Committee paper to start off with.
Yeah, thanks very much, Chair. Just to start off, I guess it's worth noting that this year we're on trajectory to deliver £40 million worth of savings, and in the last 2 years each we've delivered £30 million each, so that's £100 million, which is no tall order for any NHS organisation. But in the context of the environment in which we operate, we've seen North East London has got the fastest population growth in the country. The census data proves that, and we know that it's happening with the build around this area. The increasing complexity of patient demand, and also some of the successful things that we have done around our services, like increasing electric capacity and CDCs and surgery hubs, put more pressure on our services. We have got challenges, and I think that we will end the year in a good position, but start next year with extremely challenging financial position. And the opportunity that we have over the next few months is to try and close as much of the gap as possible with recurrent funding, recurrent saving chain, saving opportunity, so that next year the bar is less than what we expected currently to be. What we do need, and we are doing that, is a focus on transformation projects. So the outpatients transformation project, some board members will be aware of, but we need to bring it to sight of the entire board. So you can see where we'll make some significant improvements in the quality of the services. We're also reducing the cost of those as well. Moving on from finance, the performance is good. Always has been under these challenging circumstances. We know that EPR will have some impact on performance in the short term. In the longer term, expect it to improve. Fiona and I have been having conversations about our cancer recovery plans, and Fiona might want to say a few words on that. Andrew and I have spoken about the excellent work that's happened in the last few years around reducing the cost of temporary medical workforce savings, but now we're on to the real difficult one about how we transform those medical workforce going forward to ensure that we can deliver sustainable improvements in those savings. want to say a few words on that as well, just to set the tone for the next few items in this area.
Yeah, Andrew, did you want to say a little bit? I completely comes up in the RPR. Okay.
Clearly, we need to try and reduce expenditure on medical staff. As we discussed earlier today, we need to balance any changes in the medical staffing against impact on quality and safety. We've asked one of our consultants doing that sort of thing to go through our staffing numbers, particularly where we use bank and a very small amount of agency now, and look at where we can reduce rotas and make savings. And Fiona and I will review the options and take into consideration the risks associated with that, and take it forward from there. We understand the only way we're going to make significant savings is to cut the use of staff.
We'll have an item at the meeting to sort of brief down into further areas. But there's a good plan to say. On the nursing side, colleagues, we have made some real improvements in reducing and sustainable improvements in reducing the nursing temporary staffing costs, and well below the national 3% target, and will do so. So, great work that Nick has been doing in that area.
Thank you. Okay, yes, anyway, just to say, I think there seems to be a lot of interest out there at the moment. I think a lot of the noise or the pressure is coming from Jim Mackey to look at capacity and matching it to demand. So, trust that I've got people rostered on what turns out to be a bank holiday. I'm working with one trust where a particular group of clinicians are saying, I only work 4 days a week. So when I take a week's annual leave, I'll take 4 days off. Which is obviously different from some of their other staff groups. So I think the electronic patient record will also enable, if you like, particularly in areas like outpatients or theatre lists or whatever, to match what people are rostered to do or what their job plan says to what they're actually doing. And I think we'll probably start to see some opportunities to compare perhaps different groups. Okay.
Shall we look at the annual goals? Mike, you're going to talk us through that one.
Yeah, thanks, Sarah. So we bring this paper quarterly now. It's just to keep people abreast of how we progressed against 6 annual goals, and we set against those 6 annual goals, we've got 52 deliverables. I think good progress being made in kind of 4 to 3 of those, with the other 9 kind of earlier stages. But I think it's just helpful to bring this throughout the year to keep tracking how we're doing against annual goals, given the particularly difficult financial context, which I think at the beginning of the year we had concerns might put some more of these deliverables at risk. So I think it's just good to see quite generally high levels of delivery.
Text. Okay. Thank you. All right. Shall we then look at the financial position? To the month 6.
Thanks, Sarah, again. So just expanding on what Mahbooba said. So the report in the pack is the half-year pack, so to the end of September. We're reporting a £23 million deficit, which is about 10.5 million worse than planned. That includes the deficit support funding that we've lost for being off of plan. The positives are that agency we have reduced by 50% compared to last year. Bank is down by 13%, but that's less than the 15% target, but significantly less for a reduction that we need to have an affordable pay bill. We are on track for £48 million worth of financial improvement in the year, 30 of that being recurrent. That 30 million of recovery just about covers the productivity ask of the trust each year, which comes through the tariff. Therefore, it's not eating into our underlying deficit. So expect we're not seeing improvement in the underlying deficit compared to last year. As we go into the second half of the year, we really need a £2 million per month reduction in our run rate. Our income is pretty much fixed, so that has to be £2 million less per month that we are spending. Capital is a pretty good picture. Actually, we're spending best part £49 million again this year on capital. On track to have that invested, you know, most things have business cases approved, lots of stuff in place. We are into the delivery phase of all that, which means we're making progress in our high risk backlog maintenance and also replacement of all of our equipment, which will be out of date. So that's very positive. And then on the cash front, just to say, we've had the cash support for the capital programme, and we've also had the cash support that we requested in September for October.
Sue.
It's not a question, Mike. I just wonder whether it's worth telling the board a little bit about the work of the procurement partnership and how we're looking at that collaborative approach to help with the challenges that we all face.
Yeah, sure. So this has been an ongoing journey for a good few years, but at long last making some good progress. So the procurement teams from all of the trusts in North East London are we're currently in consultation phase actually with all staff to move them under one host. That host will be Barts Health, and it will bring together about 250 staff to manage. I think it's in the region of £1 billion worth of non-pay expenditure, which should bring benefits of standardisation, scale, and we'll be able to interact better with the supplier market than we currently do, to do that 5 times rather than once when we could be operating things like category towers. So some really good work. I think, you know, the arrangement will settle down in the next 12 months to 18 months as staff settle into their kind of new host home and start to work under the new.
Can I just ask, so on page 330, we've got the bank staff spend slide there. And it says in the says about the financial recovery plan, it needs much more ambitious reduction target, so on. We're going to have more and further reduction that we're going to bring the pay bill down and so on. Just can you say a little bit about how realistic that is, given what we've heard and we've talked about previously in terms of the levels of demand? Is it realistic? Is it achievable? And what are we doing? How can we tackle it in terms of the expectation? Because it's a challenge.
It's an incredibly difficult challenge. So it would mean reducing our roughly £4 million a month spend on bank to about 2. They're looking to halve it. You know, we've talked about before the increase in demand. So we know we have areas of our hospital that are open for care that aren't funded, and a lot of the staff are in those areas. So I think unless we address the demand for services and activity, then it's going to be very difficult to safely reduce staff. So that's the challenge we're really facing at the moment. As our workforce productivity, based on the NHSE data, is that we're only 1.3% less productive than pre-COVID, 2019-20. So, you know, relatively minor increases will get us back to that pre-COVID levels of productivity.
Yeah, I think it would be much nicer if you were in a comply or explain scenario, wouldn't it? Because the explanation is quite helpful, but the compliance is challenging. So Fiona, then time.
Thanks. I mean, I know we're just moving on to the next paper, but we'll talk through that, but there is a really good slide on 353, which talks about what we're spending that money on. And it's, I suppose, the good news is it's reassuring to know that we are spending it on the areas of most demand in terms of acute care.
Yeah.
And obviously that's the bit that we've got to try and convert into either not needing those staff or establishing services that are mitigating that kind of demand, albeit unplanned. So I think what's nice to see is the two reports sort of talking to each other now with much more detail. How we get into that space around reducing headcount in those areas, though, I think possibly needs quite a lot more.
Well, it really does. And I think, you know, it's helpful. The data is really detailed, but all it does is emphasize just how difficult it is, because we can see exactly where the pressures are and we can't directly control the volume that we're having to support, and we've got to keep it safe. So it's just, it's not easy. Thank you.
And I kind of feel from, you know, seeing this in your comments around procurement, but there are things here that we will see benefits realised in 2, 3, 5 years. And it would be, you know, interesting to have a deeper dive at some point around some of these longer term financial plans as well, because you know, when you're looking at it, it's such a snapshot that's affected by industrial action, you know, EPR, various other things, to actually get a sense of, as well as what's not working and in the wider environment that's affecting that, what is working, what can we learn from, how can we, you know, work on those, learn from those things and improve them as well. So I think, you know, at some point, having a broader, you know, deep dive would be really helpful.
Come back on that, I'm sure you'll have to comment.
But I mean, I think in the planning process, we're going to be looking kind of over a 3-year horizon. So I think naturally that's where we'd be done.
I think it kind of goes on from that point of, I think there is the review in our system, but then there has to be a review of our system within the system and really understanding some of the duplication that we've got. Because we know, I mean, the easiest example, isn't it, is the mental health nursing that we know is duplication, but there's far more duplication, and there's going to be potentially, my worry is even more. Because if the focus goes to community and they say we're going to now fund this amount for long-term conditions, then actually we need to start forecasting ahead that there's no point getting in more diabetic specialist nurses, because actually they're not going to be here. They're going to be out in the community. The asthma nurses, they're going to be out in the community. I think a lot of the paediatric will go out to the community. So, but once you've got some people employed, it's hard to, in a nice way, get rid of them or move them on to another role. But to do that, we're going to have to work with system partners and their forecasting at the same time, which is really difficult to do. And I expect we'll have to stall, I think, for a while until some more transparency comes about what funding is available and where it's going to go.
Yes, and I suppose the question is, you might come to it, some of those staff, if the provision is going to be in the community, the staff might need to be transferred to where the activity is and employed.
If possible, yeah.
Yes.
Otherwise, you're going to get stuck with them on your payroll, aren't you? Yeah.
Yeah.
I think we are starting to do that. We are starting to set up disease specific committees that are inward and outward looking. And Ruth is going to be on our diabetic committee, which is charged with driving up standards in the hospital, but also designing what the totality of diabetic care looks like. I think the other thing we're going to have to think about is moving away from organisational employment to sort of system, and we're able to work fluidly across different provider footprints. And if you think about our example of St George's, which is, you know, work in progress from a system perspective, it sits in Havering. It has the capacity to be a primary care centre, an outpatient centre, and a caring area for elderly people. The key to making those developments work is actually ignoring some of the boundaries created by individual employment contracts and thinking of people as a team. And we've not cracked it quite yet, because governance kind of stands a bit in the way of some of that stuff. But I think with the right mentality and the forums to do that work in, I think we'll definitely start to sort of metamorphose into a different provider type system. Thanks. That's good. Thank you.
Okay, thank you. Should we talk about the workforce improvement programme update?
Yeah, I mean, it's so counterpart to the finance update that Mike's given in terms of it shows our position. It does show the positive progress we've made, particularly on the agency staff. But that deployment of workforce remains above what we can afford at the minute, and the pressure points within the hospital are relatively well rehearsed. In terms of mental health care, it's notable going down to A&E here at lunchtime that we've got 5 patients awaiting admission to a mental health bed. It's requiring individual support in terms of their care while they're with us. And this is a steady state problem here that we're funding. That corridor care and the A&E at Queen's in particular remains a pressure point, with the department's footprint being far too small to accommodate people properly. And if you add into that the +1s, 2s and 3s on the wards and some of the unfunded service developments that we've decided to prioritise for quality and safety reasons, and that is linked to a higher deployment of workforce than we're currently budgeted for as well. And some of the conversations we're having with clinical groups are around opportunities to try to reduce spend in those areas. Lots of that work is having to be done at a very forensic level. in terms of looking at individual roles, etc. One of the consequences of our success in recruitment in recent years, our low vacancy rate, is actually a high deployment of substantive staff as well, which when you're trying to do cost savings programs does actually make it slightly harder to pull back from salary as well. And one of the pressures we've seen in recent months is an increased amount of short-term sick leave as well. You can see from the pack that has increased recently. There are areas of high pressure and the sick leave, particularly the short-term sickness, tends to correlate with most operational high pressure parts of the hospital as well. And obviously, if you've got a labour ward and a midwife off sick, you've got to cover that role with another midwife. Likewise, in the emergency department, if you need a nurse in a corridor or in a ward area, you've got to have those nurses there. Nick and the team have done a lot of really good work, actually. Nick mentioned earlier moving away from colour coding, so looking at nationally prescribed ratios of nurses to patients. And I think that does give us more clarity about where we do need to deploy extra people. But the combination of sick pressure, operational pressures, and ongoing demand across the hospitals in well-known areas such as mental health and corridor care means we are running slightly hotter than we would like to be, and certainly hotter than we can afford. And as Mike said, the focus of the rest of the year is really going to have to be on bank. I think agency-wise, we've gone as low as we can. Just now, I don't think there's anything more to be taken out of that, particularly in the course of the rest of this year. So there is going to be a focus on the bank workforce. I should also say that the non-medical staffing isn't just nurses as well. There are large chunks of other professions in there, including AHPs. We do actually use quite a lot of bank staff in corporate functions as well. It is worth noting that when we talk about corporate functions, though, it can include people who are booking clinics, people who are doing recovery and catch-up work, and we've also got the EPR cost pressures this year as well, which are funded up to a point. But that is lots of those roles that are badged as corporate are directly supporting the provision of clinical care as well. So therefore, the decision to not recruit into corporate roles, which has been a part of the last couple of years, really through vacancy control panels, does mean we're using bank staff in some areas there where there's not really any discretion about having them on the text. So positive to see such high levels of substantive recruitment. On cost pressure around banks well understood and very hard to shift.
So just on the, in relation to having more substantive staff, which generally is a good thing, what can we do or what are we doing to support staff in terms of their own health and well-being to try and address the sickness levels? And also, given some of the areas of where, also, so we need extras in maternity, we need extras in corridor care. Is there more we can do to broaden the scope of and the skill set, the substantive staff we have, so we can use substantive staff more easily and redeploy rather than look to bank in those precious scenarios to fill gaps from sickness?
So most of our bank staff is our own staff working in additional shifts. So it's not we have very low numbers of bank only staff who aren't our employees. So we're largely using our own staff to run bank shifts on top of that. I think a full-time member of staff costs you more than a bank member of staff because you pay all the on costs, you pay training costs, you pay for like annual leave, etc. So that's why as organisations you try and have a ratio of substantive to bank to agency. It gives you a degree of flexibility, and it does mean you can work seasonally, and it means you can tighten the books when you need to as well. So we have got to this position where I don't think the BHIT has ever historically been an issue. Say that we've reached levels of 3% vacancy in some areas. If you look at somewhere like midwifery, where it was 16-17% 2 or 3 years ago, and the vacancy rate is now down to 4%. That's a really good position to be in because we're a more attractive employer, so we're better able to recruit and retain people in those areas. But it does mean you're carrying a larger fixed cost, and then when you get sick leave on top of that, you're then paying the cost of sick leave on top of the substantive stuff. So this is in better financial times, this would be very much a nice problem to have. What it does mean is it makes it essential that for the medium term financial strategy and service strategy that we have a very clear workforce strategy that supports that. Now, I mean, one of the things Nick's brought in, for example, is a very clear perspective on where in some of our oncology services we can make better use of other healthcare professionals to deliver some of the services than we're currently doing. And there's a range of services where I think the workforce within BHIT is up for engagement about service transformation. See how we make better use of medical, nursing, other healthcare professionals, therapists, non-clinical staff with a lot of services in a more cost-effective way. So the real way into this isn't to say, actually, we need that 91% substantive from 90 or 89%. The way to do this is to understand at the service level what the best form of deployment looks like, both in terms of using new technology, and some of the benefits realisation from EPR will only come through a retooling of our workforce in some areas. Another area, there is clinical pathways as well. So it's a series of pressures we're not used to having to deal with as a trust. They're good things for us to deal with, but it doesn't mean that we do need to give the clinical groups the time to work through the financial implications and then the training on board and needs to go with that.
And then just think about the corporate workforce challenges and talking about technology. So the medium term planning, will we be looking to develop a digital transformation plan to make use of digital tools to help with the likes of appointment scheduling and all of that is not to replace but to support and make more efficient the staff we've got in those kind of roles?
So if you look over the last 5 years, the smallest growth of any of our workforce has been in corporate. Our corporate workforce size is unchanged from 2019 to 20. There's flat growth there. If you look into other, the really significant growth has been in consultant workforce, in the non-consultant medical body, in qualified nursing. So we have been investing in the right areas and the areas which are aligned with the increasing clinical demand that we're given. There will be some savings to be made. I should say that although we are switching on an electronic patient record, we will still be using paper for a number of years to support that, because what we're not doing is digitising £2.5 million of 2.5 million patients worth of archive data. So for a period of time, transition will still be relying on the use of paper records for a period of time to support some of that decision. It's still the case at a number of Barts hospital sites at the moment. We have got the ability through the Scanning Bureau, which is a Philip K. Dick type name for the workforce, but for us, for patients, for example, with cancer, where you want access to the records to request and stuff is then scanned into the patient record. And we also have a digital archive into Careflow. There will be some other areas where we continue to rely on some degrees of paper record as we gradually phase that out, because the cost associated with scanning everyone's records and moving that over is huge. But there are savings. We pay around £300,000 a year and for off-site storage of records, in addition to the money that we pay for the storage space at Lion Road. So what we hope to see is, as we enforce our retention policies properly, to start to run some of these costly numbers down.
Thank you. Any more questions on? Yes.
So it's not something you can answer now, Matthew. It's a request for something perhaps to be included in a future report. The employee relations page, which talks about the number of cases open and what they're open for, I would find it quite useful to understand how long they're open. So how long does it take to close them, and whether that varies between kinds of cases. Just, is there any learning? And also, what is the impact? Are people out of the workplace as a result of that item, or are they in the workplace? So, yeah, I could be worrying about that thing.
So we've seen a real improvement in the number of VR cases that are open, and the workforce team have improved the skill set of the people that support the clinic groups there. And I think that has gone from being a source of some real unhappiness to an area where teams are generally feeling better supported, although with still some weaknesses there. The workforce team is currently concluding a restructure as well, which is going to provide the clinical groups with more direct support and expertise in terms of the management of those cases. What we have identified is that we do end up with more cases than should be going to a formal status too early. And we are now, through things like mediation training for managers and active bystander training, etc. What we're encouraging is formal conversation at the point where the conflict initially arises. And what we're increasingly finding actually is that with greater skill sets dotted around the workforce, we can deal with these problems at the source, rather than someone feeling at the point where they have to contact HR and ask them for advice to get into. So I think we have managed to reduce the number of ERs, or employee relations cases overall. There are still some very difficult ones in there, and a small number of those cases that people are out of the workforce as well. The most difficult ones tend to have a degree of discrimination in there as a source of some of the unhappiness. And the team are very actively trying to support clinical groups and management of that, but they can be very tricky and very time-consuming cases where it's important for the expertise they support from others. Well, it's got very busy clinical portfolios as well.
And the majority of the ones that, if you looked at the case type, are actually dealing with absence management.
Yeah.
So in a sense, those people are active for the workforce because they're absent. And actually, the reason that it's an employee relation issue is because it's managers dealing with either persistent short-term or long-term absence. So it tends to be that rather than disciplinary or grievance. And as Matthew said, we get quite a lot of reports on this at PCC. And we are now using mediation much more. Staff signed up to that. The staff groups are generally happy, so it tends to that combined with the work around bystander. Yeah, which Caroline's pushed at PCC and courageous conversations and the manager's license have all combined to us being able to use mediation much more. But the biggest chunk of those open cases is absence management.
And I guess looking at just data about open cases doesn't really tell that story. So that's why I'm saying it's not necessarily an answer today, but a slightly richer interpretation of what's happening in that space.
I can't think of any cases where formal grievances have been resolved in such a way that you're left with a well-functioning team afterwards. You know, the process of going through formal grievance can be really damaging to team engagement and to relationships between managers and staff. And I think the more that we can empower people to deal with stuff at source and with confidence, so we're getting better feedback from staff.
I think it's also worth pointing out with cases that when you do have disciplinaries, performance, things like that, there will inevitably be absence. But when we discussed this at PCC, a lot of the cases are getting more complex, particularly because of the use of AI as well, and the teams are seeing this because you can put your information into ChatGPT or whatever, and you get a very, very fulsome case referenced response that from HR terms, it will take an awful lot more time to work through than it would have done in the past. So that slows things up quite a lot.
Right. Okay, thank you. Let's move on to performance.
Thank you very much. Okay, so a strong performance report for September. Lots to celebrate across the organisation. Just taking you through the headlines. We are remaining very strong on UEC on our 4-hour all types performance. 79% is something we only dreamt about a few years ago. So huge congratulations there, despite the backdrop of possibly the busiest month, September and October, in the history of VHIUT. So, again, this is about people working hard. This is about people being committed. And this is the result of some very, very hard work across the teams in ED. And the bugbear of UEC for us continues to be our type 1, our ED only performance. And it's a really tough one, mainly because of flow, mainly because of admitting. However, I have seen recent improvements around the King George's ED with the opening of the medical ESDEC. Early days, but providing an alternative place of care outside the ED footprint is starting to change the behaviour of the clinical teams, give patients different options. And so bit of a push around that. We will see post EPR some downturn in terms of some of that processing performance, but the ingredients are right. We know what we need to do, and we just need to keep at it. Moving on to within the all types, our type 2 remains strong. We have a women's ED. I know some of you have visited it recently. I'd personally like to upgrade that physical space. I don't think it's conducive to women attending with emergency gynae problems, but the team, despite that, are doing an extremely good job of receiving numbers of patients that come every day. And equally in our eye casualty, high performing area, lots of activity, well done to the team on that. The the IPR is never ever presented without a slide on mental health, and that's because that is topical. It's topical for us, it's topical for North East London, and I know that we talk about it in many committees. Okay, so the data speaks for itself. In September, despite there being investment in mental health services within the mental health provider, 22 section 136 attendances were at King George, 10 at Queen's and 3 at Buffets. So I want us to keep talking about it. I want us to keep carrying on looking at the data. And through our operational integration group with NELD, we don't miss an opportunity to discuss that with our partners. I don't have an action plan at the moment that is fully worked up, but I do know that as a sector, as an ICB, and certainly as a London group of trusts, this is one of those areas that I think we should all be focusing on with a priority number 1. For patients, this is not ideal for patients. This is not ideal for families, and EDs, despite all the hard work they do, are not the appropriate environment for patients with mental health conditions. We heard more about that on the seminar, so I won't talk any more on that. A couple of high-level updates from our sites. So King George's have done some really good work reducing length of stay. There's lots of data in the slide, but a couple of pieces are you can see the criteria to reside patients going down, which is reducing length of stay. And unfortunately, as soon as you stop doing that, it bobs back up again. So we're running with around 30 patients, that's a ward's worth of patients at King George's who are medically fit to be in anywhere other than an acute bed. Queen's wise, again, we are running with about 70 patients, so two and a bit wards worth of patients medically fit, and we have seen, it's fair to say, a deterioration recently in our negotiation, our ability to negotiate alternative places for patients to reside post hospital stay, but we continue to work through that on a daily basis with a huge discharge to who spend their entire lives doing that. I'll just move to planned care. You know, we're very proud of the work we've done in planned care. We've really focused on the right things. 52 weeks is 0.9% of our total PCL. National standard is 1. We are committed to delivering the 65-week eradication by the end of December. And we are continuing our focus on making sure that the majority of our patients are at the front end of the waiting list, not the long waiting end. And so I think all the teams that contribute to that, including the admin staff who do a huge amount of work validating, ought to be congratulated for sustaining and delivering very, very good levels of performance around planned care. Moving on to the DMO1. DMO1 was, you know, don't want to brag, but it's so good it's not worth mentioning really. A couple of red things, but not disproportionate to the amount of work we're doing in the service area. So 2.6% is brilliant. Size of our diagnostic activity and demand, the work that we do. You can see there's 10,500 patients on the DMO waiting list. To have all of those, our 2.6% seen in 6 weeks, that's pretty good achievement, and contributed to by many different individuals. In terms of productivity and efficiency, I think when I started here 3.5 years ago, I think my priority was to reduce the waste of theatre sessions. It was the biggest problem. And as you can see here, they're so small now, the amount of theatre sessions that don't get used, they're under fallow. So I think we've really cracked that. And I think as as in a plan care unit, we really are working very well. We are innovative, we are transformational, and there's a lot to be celebrated, both within our King George's, but also our ability to convert surgical cases into day areas and non-theatre types environments. And I know, Mahbub, we wanted to talk a little bit about cancer. We mentioned that earlier. So I've got two things to say about cancer. One is we do have strong performance in cancer. We've got a huge waiting list, 4,500. Our PTL in cancer is as big as most cancer units. So don't underestimate, should I say, the size of the task. The encouraging news is that our 31-day performance, so that's treatment from diagnosing, is, let me put my glasses on for that, 95%. So, you know, the bold statement is if we know you've got cancer, we will treat you in 31 days. That's a very important measure for patients, knowing they've been diagnosed with a malignancy and then being treated. So lots to celebrate there. The focus for me remains the over 62-day backlog, and I've got a whole team approach to working through the backlog there. We can run, or should run, with about 120 patients in that space for complex reasons. It's not because we haven't got around to doing anything. It will be tending to be around compliance. It'll tend to be around complex investigations, and it's quite often to do with different teams trying to communicate with each other around what kind of tumour they're diagnosing. So I've got a recovery plan for breast, gynae, lower GI neurology, which gets down to the details, tells me exactly what we're doing for which patients, and I am very confident that with the exception of a little bit of bumpy EPR landing and data, we will be all over that by the new year. Thank you.
One thing you said, in relation to the medically optimised, ready to discharge, we're having we've got a reduced ability to negotiate alternative places for them to be. Why is that?
So I think there are issues with some of the local authorities. I think there are many funding discussions that need to be had about which agency is funding which bit. There are differences between social care and continuing healthcare. There are, in areas of huge deprivation, the burden on social care, the burden on rehousing and re-identifying where someone might live are significantly higher. And I think that we know that the NHS social care local authority, that whole negotiation point, it takes time. Yeah. And as local authorities come under more pressure financially, I suspect that there's more about, you know, the process and ticking all the boxes around until you find that right place and who's going to pay for it. And I think in easier times financially, there are probably less gateways, is what I would say.
So that sounds like it's more about the funding and the agreement rather than there's a lack of places for them to go to.
It does. It is.
And is that the case?
That's right.
So there would be homes or supported living or whatever.
Yes.
If only to get agreement on.
Yes.
We should pay for it. Yes. Okay, that's really helpful.
And I don't think that's going to get any easier because local authority budgets are getting tighter and tighter and tighter, and they can't run deficits, so they have to reduce services. That's all they can do. I think the other thing that we suffered from is having an exceptionally some of the highest rates in Redbridge in London of people with no recourse to public hospitals. So we have huge numbers of people in the hospitals who don't actually have a home to be discharged to. And it gets difficult as we get into winter because nobody wants to discharge somebody onto the street when it's raining outside. So we just live in, we live in a place where we have quite a lot of challenges with the kinds of housing people actually can be discharged into, even if we were prepared for these.
Yeah, we also have a lot of patients that appear in Redbridge but might once have lived in Brentwood, or, you know, they've touched one other local authority and appeared somewhere else. If you add on to that homelessness and no recourse to public funds, you can imagine how many agencies we are negotiating with. And let's remember that once a patient's in our bed, we take on the role of we're advocating for that patient, as well as trying to manage getting them to a place where they can live as good a life as, you know, we can give them. So this was said in the context of identifying risks for the board, rather than throwing other agencies under the bus and blaming everybody.
It's really important to understand whether it's a provision issue, a funding issue, an owning and responsibility issue. Because if it was lack of provision, it's a different way to try and solve that. Whereas if it's accessing the funding, which doesn't make it any easier, but you know, it's a different conversation, isn't it? Yeah, and it's a system approach.
We do have far fewer patients who than we've had.
Yeah.
And those numbers
Oh,
are
we had.
significant, which I think is positive. It's noted, one of the areas we want to look at over the course of the next year, so weekend productivity. And it is notable, if you spend some time with the discharge team, that the days of classifying it into simple and complex discharges is largely gone. There's very few patients these days, you know, more for a period of time, but it's just a case of saying, get them ready and get them home. There are other things to organise in multiple cases. We are now in an environment where domiciliary care packages are increasingly more expensive than some of the lower cost residential packages, which is quite a different dynamic. If you look at that, plus you look at the kind of medication requirements, people plus the therapies, assessments, etc. that are required, finding those simple patients can go home on a Saturday morning or a Sunday morning. It doesn't feel like we have that population in our bed base anymore. I think the flowers have been turned around for us, actually.
Yeah, a lot of patients come, certainly, I mean, you know, the elderly cohort attend when they're not coping at home. And so what we're now doing is we're rehousing them.
Yeah.
You know, we're not putting in a package of care in many instances. We are working with them and the family to identify what the next place they're going to live in. And that's you know, it's a human issue. It's not anything that we can change, but I do think that when you are working in socially deprived areas, there's a much more acute need there around intervention from other agencies, whereas in some areas that would have been sorted out by extended families and other things.
I think the other issue is in the nursing homes, particularly, their costs have gone up. So what they're doing is asking for more like one-on-one care. But it feels similar to what happens in schools with around EHCPs, is that funding goes in, but it's not actually necessarily then for that patient. Then they find it hard to cope with that patient, and then they end up back at the front door. So it just seems to be this turn cycle. But they have all increased their fees. So the other thing they're now doing is also going back out to families and asking for top-ups, which families have never had to do before. And there's a cultural reticence, particularly in some areas of Havering where patients are quite asset rich, but cash poor, but they don't want to release assets. Like, and it's like the rainy day is here, like this is the time to release the asset. But again, families don't want them to because they see that as their inheritance, their right. And it's going to take a national shift, I think, for that to really happen. But it also delays everything, because even if they sold the asset tomorrow, they're not going to get released from here tomorrow. I don't know how we get past it, but I do think it has to be a very early conversation in some of our admissions, not from healthcare, but from social, much sooner.
Really helpful, but let's not take away from the fact that in the main, performance is really strong.
It is.
There's a lot of really good progress against a really challenging environment, and I think that's really well said.
And just to emphasise, the performance will decline or while we get used to the new system. I think we know that we'll be slower. And we also know in terms of the waiting list, that the waiting list will artificially increase as a consequence of data uploads to the new system as well. And that validates some of that off as well. So we're expecting a short period of that before we recover into the new. That, in addition to winter and increased demand, will mean some fluctuations in sort of the next few months. We'll bring through the.
That'll be December board will see the November performance data, which will be half EPR, half not.
Yes, this is the interruption. Okay, brilliant. Okay, thank you. Let's move on to audit and risk committee. Sue, you're going to take us through the table.
I am, thank you. So we've met once since the last board, and we are in what I would describe as the quieter phase of the life cycle of the audit and risk committee. We aren't quite launched into the next external audit, and we've just started to see outputs from a relatively newly appointed firm of internal auditors. So I'll just highlight a few components. So Mazars are our external auditors. They have met with our finance teams to look at lessons learned from last year. And to remind the board, last year was a really challenging year because we had particular delays in the previous year's audit whilst we were doing that year's audit. So it was tough yards for both Mazars and for our team. But we did finish last year's audit on time, and that has afforded us the time and the opportunity to do some really deep dive work with Mazars and with an appointed firm of consultants to look at how we can improve what we do. So a very positive meeting with Mazars, some clear actions coming out of that as to what we need to do to improve. We as an audit committee, I think, are raising our bar quite significantly and saying we do not expect to see any material level of audit errors going forward. And aligned to that, slightly out of order in the report, we've had an external review undertaken of financial governance processes, and the findings of that align very much with the findings of the external auditors. And we have some detailed action plans coming out of that, which Mike and colleagues are looking to implement. They're quite significant pieces of work, but it is our expectation that along with the lessons learned from Mazars, will give us a much cleaner, tidier, more straightforward year end as we launch into the next year of audit. So that feels very positive, albeit not yet concluded. Other things are highlights. I'm not going to talk about everything in the report. We received our first report from our new internal auditors on fit and proper persons. That was significant assurance with minor improvement opportunities, some stuff around updating policies. And I think the other big thing we got from RSM was where we have overdue management actions, we think we still have a bit of optimism bias in terms of the dates that people put on actions as to how quickly they can get them implemented. So we're asking our executive colleagues to really give that a serious look at any time they agree to an action plan and dates. The other thing that the board should be aware of in terms of internal audits, we did have in our annual plan a proposal to look at the implementation of the EPR, something that gets mentioned in every single committee report, I think, today. So it would be remiss of me not to add it to mine. And the intention had been, when the implementation date was a bit earlier in the year, to look at how well that had gone. We concluded that timing was not our friend in this space. So we've swapped that out and we've brought in instead an audit of the grip and control checklist, which I think is very relevant to all of the conversations that we've had about making our books balance and what that might look like. Bless you. You blessed my report. Other things to highlight, local counter fraud work is ongoing, and we did as a committee have a bit of a conversation about cybersecurity risk, and we have asked a relatively newly appointed CIRO to come to the committee to talk to us about management of cyber risk. So that will be coming forward to us in due course. And then the only other bits I think I'll mention are BAF and corporate risk. we are coming to the end, I think, of a fairly major transformation piece of work around what our BAF looks like and what our risk register looks like. As a committee, we are absolutely delighted with the progress that's been made in this space and would like to very much acknowledge the work that Linda has done in genuinely championing both pieces, but Kerry and colleagues in the nursing team in how they're reshaping the risk register. So we've now got a true view of corporate risks and not just divisional risks. And of course, this is a movable feast. Every time we look at it, things have changed and there's more work to do. But we as a committee are feeling this is genuinely now becoming a tool for us to help manage the work of the trust. And Mike very much is championing how we use risk appetite, how we use risk tolerance to determine our actions and the things that we take forward. So really positive piece of work. Linda will be presenting the latest back position shortly, but I just wanted to pay tribute to, it's been a long piece of work and it's required the whole executive to participate in it, but we now have got a really good set of tools to work with. So thank you. I'll leave everything there. Obviously, a couple of items will be coming in their own name imminently, but if there's anything that anyone wishes to ask.
Just I saw Hillary's face. Ben Conway has been appointed as our new CIRO, and he's picking that up. We're doing lots of work with Barts to look at opportunities for shared work in there as well, particularly around some of the back office functions where we're both replicating work together. But Ben's working closely with his counterpart there. That links then also into the cyber security risk that Sue mentioned. One of the advantages of our paper-based system was it was entirely hack resistant.
Until somebody faxes something. So I think cause massive embarrassment when fax stuff went, to an empty room on the other end. So, but yeah.
So, so for some parts of our service, cybersecurity is a new thing as well. And again, we're looking at how we can work with parts to
I think with the last item, we heard about discharge and the challenges there. I mean, it seems like only yesterday we were standing in the old ambulance base talking about how the HRUT could tighten up their processes and procedures and how that's bearing fruit, on our side. But also with this, I mean, Sue, you and colleagues have put so much work into this. And when we think about a year ago where we were, again, it's not the 6 month, it's not a short timeline, these things, but I was just incredibly heartened to not only see the progress, but the approach as well. So, so I'd like to like that to be noted.
I'm the cheerleader of the team delivery.
Can I just ask, you mentioned about we're in a very different place in terms of audit compared to last year, where of course when I arrived, you were still clearing up the challenges of the previous year. But one of the things I remember was there were quite a number of recommendations from the previous audit that were sort of outstanding because we've been so busy trying to get things cleared up. So I just wondered, are we tackling those and are we making progress on some of those historic recommendations that we knew we needed to get to so that we are on the front foot as we head into the next phase?
So the short answer is yes, it's all wrapped up in those action plans, but I'm sure Mike would like to give you a bit more than just yes. Or maybe you wouldn't, I don't know.
Well, there's a range of plans. I think there's a range across leadership, there's a range across kind of technical stuff, there's a range across some basic things, I think. I think the kind of the leadership is and the culture in the middle is the really key part of the project. So hopefully we'll have detailed plans kind of all signed off, well they'll sign off, we're very clear on who's doing what. So I think we'll be in a good sustainable place hopefully by the end of the year.
Good. Linda, who's the trustees?
Oh, right. So the report was received in the Audit and Risk Assurance Committee. We've used the C 4 times since the last met, so seeking board ratification. Use the series. Order, anything to comment? Happy to approve.
Thank you very much. In which case, also with you, the insurance framework, this wonderful piece of excellent work.
Thank you. I'll just highlight final 6 key points from the exec summary. It's quite a detailed document. So the programme of deep dives and board committees continues. So we've set out there in detail over the past couple of months. The EPR and digital risk has reduced in school down to 15. So that's one of the key movements in schools. We know these risks don't move quickly and quite slow process due to the size of the areas that we're mapping. In terms of our biggest risk, that remains financial sustainability. That's outside of appetite and tolerance, along with 4 other risks, which are set out on page 2 of the summary report. The 6 risks that are inside tolerance outside of appetite. And then we have 2 risks, which is partnership working, anchor, and planned care, which are within appetite and tolerance. So as we go through all of these board committee reviews and into the committee, we are increasingly focusing on, are we in tolerance and risk appetite? So we need to focus on those areas. The BAF is trying to ask the question, what controls and actions we're looking to get risk positions within tolerance, and increasingly we're trying to focus on narrative around that, alongside explaining the risk position in accordance with the really specific deliverables that we've set for ourselves in year 1, our goals and targets. So we're constantly reviewing how we talk about the position. And really that's just at the moment. I'll just leave it there. The details of each of the 13 risks is within the report. Obviously, as we come around in the planning process, we'll be looking into our objectives again for next year and looking at how we set those in the context of how can we measure them and how can we put on risk and appetite in that context. And I think having set the appetite this year is even more use in the next planning round. Happy to answer any questions.
So just to emphasise, we're now using the risk appetite as a live tool in discussions as well. You know, I think a year ago it was just a sort of toe in the water, but now it's very different from a live tool discussion.
It is a helpful document to read and get a sort of full perspective of where is the risk and what actions are going on and where's the assurance, I suppose, in terms of how we're mitigating some of that. So it's a much more useful document.
And I think with the medium-term planning and also the financial framework we're trying to work within, it's become very helpful to talk about. You know, where we might, it was notable during the AMOS meetings and the CQC and conversations recently. We've been able to point to investments in alternative that have led to measurable, recognised improvements in the services. And when you apply that risk tolerance around to where would you take out cost versus where you maintain investment, it's actually a very, very helpful sector.
Good. Any other comments or questions on that? No, really helpful, and I'd echo the thanks to you, Linda, and the team, because it is a meaty piece of work to get a BAF in order and to become a workable and dynamic document that we can actually use. And it's timeless. Brilliant. The dog with a bone. We like that. I know. Never give us a reputation. I'm sorry. Well deserved. Right. Okay. Anyone want to raise anything under AOB? Just be as ever very happy to take any feedback on meeting effectiveness and anything of that nature. So please do share if you have anything you want to raise. And open to any questions from the public.
Yes, Chair, my apologies for late notice. There's 2 questions. Perhaps it's easiest if I, with your permission, give you the 2 questions at once. The first one, there's been a report on the BBC the 27th of October, and Health Week, there's a warning that services will be cut unless NHS gets an extra 3 billion. So I'd be grateful for a report on that. If you don't get your share of the 3 billion, it's put you on the spot. So I'm not sure. So that's the first question.
Yeah.
might happen with that. Your board papers today suggest that corridor care is a really big issue. What stands out for me is the reports about also care getting worse due to corridor care. Also care, I'm guessing, is a factor in morbidity, increased risk of death. So would it be fair for me to report that due to corridor care, death rates, risk of unnecessary deaths, there's a jargon for it, excess deaths. The excess death rate is increasing as a consequence of corridor care and also care.
So I think I'll ask Nick to talk about pressure ulcers in a minute. I think in terms of the finances, Andy, we don't know what our allocations are yet for next year. And we also don't know whether it's going to be over 2 or 3 years that we need to try to come up with plans for a sustainable funding position. So that will have impacts on what we have to do in terms of services. What we're trying to do, I mean, we've been for the last 5 years expanding services, expanding staffing numbers. We've got around 1,200 full-time staff, more than we had 5 years ago now. The majority of them are clinical staff who are caring for people who are coming through the doors of the hospital as a result of increased demand. So the territory we're in is about trying to make existing services more productive. We've managed 2 years of taking out £30 million worth of recurring costs through that kind of productivity and efficiency. And you heard me talk earlier about what we do around our workforce. And really, it's the workforce costs we need to pay attention to, whether there's opportunities with the advent of a digital patient record and increasing use of other technologies to cut costs there, and whether there's better ways to use and deploy the skills mix within our workforce to try to push down those costs without compromising services. It is very difficult at the minute to balance the financial pressures against the growing demand and our desire to maintain quality in services, because we're happy that we've come out of special measures, and we're very proud of the improved performance in terms of access times, etc. And we don't want to lose sight of that. So we are working very hard at the minute to balance those financial pressures with the workforce costs and maintaining what we hope is a better quality service to our patients. So it's a hard position that we'll have to keep a close eye on once we find out next year's allocations. I think Nick might be able to answer on pressure ulcers.
Yeah, I mean, corridor care always, allows for greater risk around pressure ulcers, but we've got quite a lot of mitigations in place in terms of we're able within the corridors to put pressure relieving mattress in some of the beds. We've also recently purchased some toppers that go on top of the trolleys, which have got relieving properties as well. So we're trying to do as much as we possibly can to mitigate the risk. I must say it hasn't come on my radar that we're suddenly seeing an increase in pressure ulcers, but it is something that I can double check just to see if there's some, that we have seen any change in the pressure ulcers. But certainly the staff are very committed to mitigating it as much as possible. But when you have got frail elderly patients, generally in a corridor, it does mean that there is a higher risk, but we're doing as much as we possibly can.
We haven't seen any increase in our mortality rate. It's measured
Not
through
increase in mortality.
shipping or HSML.
No.
They're both well within tolerances of mortality.
I think you've also heard us talk about the increase. One of the areas where we've continued with our increased spend in workforce, and particularly bank, is to support the corridor care. So we're making sure that people are being looked after and kept safe, even though we should be trying to cut costs. We're not compromising on quality and safety.
Thank you for the answers.
Thank you. Thank you very much. So our next meeting in public will be 15th of January, and that will be also here at King George.
Fully digital.
We'll be fully digital. Digital check in the whole room. Yeah. Thank you very much, and good luck to you in the afternoon.